Good morning and welcome to Vishwa Talks. My name is Trishan and I thank you all for attending today's event. For those of you who have attended a Vishwa Talk before, a warm welcome back. And for those of you who are joining us for the first time, here's a little bit about us. Vishwa Talks is a space to expand the horizons of your mind. Every webinar, we call experts from different domains to discuss and examine opinions, issues, problems, and perspectives. Each webinar is an interactive session where we all walk away with more respect for each other and a deeper understanding of the topic at hand. If you miss a session, please visit our YouTube channel for a full library of past Vishwa Talks on interesting topics. We are honored to introduce our esteemed keynote speaker for today's Vishwa Talks, Ms. Sarga Lingaraju, a distinguished counseling psychologist and hospice administrator at Sparsh Hospice, Hyderabad. Ms. Lingaraju's commitment to palliative care and end-of-life care is underscored by her comprehensive training from esteemed institutions like Stanford and Glasgow. One of Ms. Lingaraju's notable contributions is her tireless work with families to ensure that aggressive interventions are thoughtfully considered in end-of-life care, aligning with the patient's wishes. Moreover, she extends her expertise to rural communities through extensive outreach programs, striving to promote the uptake of palliative care where it's needed most. Her dedication to improving the quality of life for those in their final journey is truly commendable. With her expertise and unwavering commitment to improving the lives of patients and families, Ms. Sadhar Lingaraju promises to be a beacon of insight and inspiration in our upcoming Vishwa Talks webinar. Let's welcome her with enthusiasm and gratitude for sharing her invaluable insights with us. Before we get started, I'd like to inform our audience members that our speaker will be taking the questions from you after our main talk. So please leave your questions in the chat or use the raise hand tool and we will allow you to ask your questions in person. I request everyone to turn on your webcam for the interactive part of the webinar. Now, without further ado, I invite our speaker to begin today's Vishwa Talk. Good morning, ma'am.
Very good morning. Thank you, Trishant, for the wonderful words you had for me. And it's a pleasure to be on this platform. So today we are going to start this particular topic that I think you all have been informed about. So can I request Preeti to start the PPT, please? So hi, everyone. Today we are going to discuss about enhancement of quality of life through compassionate support. So here you can see that there are two different words, two good words, good phrases, like quality of life and compassionate support. So when this particular topic is being discussed in the context of chronic diseases, when we say chronic, what we are meaning is that any disease that requires the patient to fight it out for a longer time, like months and years, and requires the families to invest their time and leave their routines to support that particular patient, like cancers, chronic COPDs, liver failures, kidney failures, and many such end-stage dementias, different types of dementias, Parkinson's, any of these chronic illnesses which have a lot of burden on the family and the patient. These are the diseases, and in that particular context, we are going to discuss the quality of life and compassionate support. So can I have the next slide, please? When we are saying compassionate support, what exactly are we talking about? When a person is diagnosed with a chronic illness, so the first thing that he does is visit a hospital, a regular hospital, gets to meet a physician or a specialist, gets a battery of tests done, a diagnosis is arrived, and he starts his journey with cure of the disease. It might take months, it might take years. When the journey starts, somewhere in the context of curing the disease, with our eagerness to cure the disease, the family or sometimes even our medical system loses the concept of the patient being a human being, wherein we lose that the disease is not impacting just the body of the person. Somewhere it is impacting his emotional status, and somewhere it is impacting his family life, his social structure, and more importantly, it is impacting his spirituality. Is our medical system equipped to deal with all those things? Because of the volume of patients, which keeps on raising, because we see number of, this much of, percentage of people are diagnosed with one particular chronic illness. It keeps on raising. That particular statistics, if we see, it keeps on raising. So how do they equip themselves to take care of this particular thing? That's when a specialty of medicine has been introduced, which is called palliative medicine or palliative care. Because with that particular line of medicine, the intention is to offer compassionate care to the patients. So when we are saying compassionate care, along with the pain management and relief from the symptoms of the disease and the treatments that they're undergoing, we also look at the impact of the disease on their mindset. Well, how is it affecting them? Are they entertaining any suicidal thoughts? Is it impacting their mental well-being? Are they depressed? Are they angry? Are they guilty? So we try to understand that impact. And next thing we do is understand the impact on their social structure. So when this sort of, especially cancer burden is so high in our society that the patient loses his job. So the breadwinner is not there any longer in the family scenario. So how does the family survive? What happens to these kids? Do they get dropped out of schools? Nobody is there to pay their fees. And there is a lot of social discrimination. There is so much of taboo attached to many diseases. Many people have, they do not have complete information if cancer is contagious or not. Because of that, even now here, many stories about they're not being allowed into their communities. They're not being, made part of any decision making in their communities. So this is like they're suddenly cut off from their community. We are all social beings. We are all social animals. We want connection with our community. We want connection with our society and family especially. Certain times, even these family ties are disrupted because of the disease. We see many times that, especially in certain cancers, divorces happen. They're abandoned. They're pushed out. Recently, we came across a case where the patient is asked to leave the house, vacate the house immediately, because in case death happens, it's not all right with the house owner. So there are so many social issues. So unless we address these sort of issues, it is not a possibility to offer complete support for the patient. Just because he takes some pain management medications or just because he's undergoing some treatment, these issues still remain the same. They're still disturbing him. They're still causing him a lot of stress. So how do we handle all that? Who does that work? Is there a specialty medicine? That's where the answer or that particular question the answer to that particular question is palliative medicine and palliative care. And most importantly, the spirituality of the person is disrupted. When we say spirituality, we all have a reason to live. We all have a hope that tomorrow is going to be better, or today's problem is just temporary for the day, and we might, look forward to a better day tomorrow. But for patients who are fighting these sort of chronic illnesses, there is no such hope. Tomorrow might be worse. If not same, it might get worse. There's never going to be a better day. So what we all have to understand is that, so what gives them hope? What gives them that support that they need to get up and face the day with the same enthusiasm? Or what gives them that strength that they're still alive, they're not dead yet? So how do we give that support or hope for those patients who have to face every day with the same set of problems, which are worsening or improving on a daily basis? So when we are talking about compassionate support, we are ensuring that a patient is handled from a humane angle. Apart from addressing his physical issues, we will also be addressing his emotional, social, and spiritual issues. that's when the healing for the patient starts. When he feels supported, when he feels understood, then the healing actually starts for the patient. All of us have a need that we are understood by our community or our family. When that need is met, that's when the healing starts for the patient. So that's why we are talking about compassionate care. In compassionate care, especially palliative care, the specialty is that we do not involve mainly in the cure of the disease. There is a specialist for that. So we'll talk in context of specifically cancer. So when we're talking about cancer, there's an oncologist, there's a radiologist, and there are so many special alternate medical professions which involving in curing the disease. There is a line, that is the palliative care line. What it does is it addresses the pain associated with the disease or the symptoms associated with the disease or the pain and the symptoms which come as a byproduct of the treatment they are undergoing. Especially chemotherapies, radiation therapies, they give a lot of side effects to the patients. And sometimes it is not possible for the mainline physicians to address all of them. So there is a component of palliative care requirement for these sort of terminal patients, these sort of chronic patients. So physical aspect is not for the cure of the disease, but only for the palliation of the symptoms or palliation of pain. So we have to be very clear about it. Palliative care physicians or palliative care medicine does not involve in curing the disease. It involves in palliation of the symptoms in such a way that they work on the experience of the disease for the patient. The patient might be experiencing or is diagnosed with a very serious illness like cancer, but his experience of the disease should be in such a way that he doesn't lose hope. It should be in such a way that his mental happiness is not disturbed that much. When the pain is not addressed, it has a toll on all these fronts. It affects his mental peace, it affects his social structure, and it affects his spirituality. So by addressing this pain and symptoms, the palliative medical people, they achieve an impact, a positive impact on all three other domains of this person. Next slide, please. So we have discussed what is compassionate care. Now, the second phrase that was there in the title is quality of life. Quality of life is so personal for everybody. What I consider quality is might be very different for you and all. So we have to consider what the individual person is feeling or perceiving his quality of life to be. If a person who doesn't have 2 square meals a day, if you provide him good food, he might feel that, yes, my quality of life is good. But that's not the answer for everybody. A person who is screaming at the top of his lungs with pain and he's suffering with many side symptoms of the disease and the treatment, if you palliate them, that's good enough. He thinks that his quality of life is good. So we have to understand each person's requirement. We need to interact on an individual level, both with the patient and the families, and understand what will improve their quality of life in the context of living with a chronic illness, like the ones we have mentioned before. Like, for example, how is it impacting his health or his total wellness? How do we go about it? How to resolve those issues? Has he lost purpose in his life? So how to work? What can the psychologists or the counselors can do about it? So then connectedness. Is he feeling connected with the society or with the family, his own family? So how do we resolve those family issues for them? Is he feeling supported enough that he's feeling secure? I'm taken care of. There is something there for me to take care of. There is a team or somebody who's there for me. And is somebody respecting my wishes, patient autonomy? Is somebody taking my wishes into consideration? Or am I being, pushed into something which I don't like? So these sort of things mean different things for different people. People coming from people who have not much of formal education, coming from rural areas, they do not understand what autonomy is. They don't relate to it. They say that my son wants me to do this, my daughter wants me to do this, so I'd like to do. But for some people, it doesn't mean that. They say that I didn't want to go for chemotherapy, but my family is forcing me. My word has no meaning just because I have a disease. They have lost their own self-worth because their word is not taken seriously by the family and the community. So we have to understand what it means, what quality of life means for each person. Like, for example, we have to understand their expectations. We have to understand their value systems, and we have to understand their emotional status. Then we can offer that particular quality of life for the patient. So the goal of compassionate care is to improve the quality of life of a person living with chronic illnesses, to improve the experience of the disease in such a way that he doesn't suffer in all the 4 planes that we have discussed just now. Thank you. Riti, can I have the next one? So who can offer this particular care? Who all can offer palliative care? And who can take it? When we say who can take it, any person who is seriously ill can take this particular care, palliative care. Here, if you see me saying the palliative care, you might think that why is she not using palliative medicine? Because palliative care is offered by a multidisciplinary team, wherein because it is talking about a care on social front, emotional front, and spiritual front, which is not done by the physicians. So that is the reason we use the term palliative care. We don't use palliative medicine. Palliative medicine is part of palliative care. So any person with any serious illness can avail it. Can they avail it when they're undergoing some treatments? Yes, of course they can avail it. Can they avail it when the treatment options are closed for them? Yes, they can avail it. And we'll discuss about it at a later time in our session. So this can be availed by anybody who is fighting a chronic condition. Next slide, please. So what's the goal of palliative care? As we have discussed, the goal is to offer compassionate care and palliate their symptoms, and then improve the quality of life of the patients and the families. One more beautiful thing about palliative care is that it does not talk about just the patient. In most of the hospitals, when we go in our mainline medical system, the concentration is on the patient. What is the patient facing? How can we help the patient? How can we cure the disease for the patient? But what happens to the family, which is equally struggling along with the patient? Who is looking out for that? The disease has altered their lives too, especially in a close-knit societies, close-knit families. If a person is diagnosed with some sort of chronic illness, it affects the entire household. Are we addressing the issues of the family? So in palliative care, it is not just about the patient, it's about their families too. They might not have any physical issues, but they might have many psychological issues. They might have many social issues and spiritual issues. Many times we face questions like, my father was a wonderful person. He was such a kind-hearted person. He has helped many. How come he's diagnosed with cancer? So many people have these sort of deep questions because our religion or our belief system teaches us that if we are good, only good happens to us. And we take that disease is a sort of punishment from God. So these are deeply ingrained into most of us. I'm not saying everybody, but most of us. So when this is ingrained, the families also face a lot of distress. If a person so eminent and so good-hearted and so kind is diagnosed with cancer, then what about us? I haven't done any of those good deeds. What about me? Will I die a bad death? Am I going to die very horribly in a lot of pain and things like that? So these sort of questions, they start questioning their own mortality, and they start doubting their own value systems. So here in palliative care, we improve the quality of life of, along with the patient, we improve the quality of life of families too. So it can be taken by everybody who is undergoing some curative treatments for their chronic illnesses. So as I said, here, if you can look at the diagram, it is talking about the patients and the families. And the best part of palliative care is if somebody is undergoing a curative treatment for cancer, like radiations or chemotherapies, it is mandatory that they go to hospitals, they go to medical facilities, they're uprooted from their homes. As a simple example, I can say, if we have a very bad headache, the first thought for us is, let's go back home for the day. Let's wrap it up and go back home. If a simple headache or a simple, small acute problem like that can make us think like that, what about these patients? They're uprooted, they're hospitalized for a very long period in their, in the medical facilities. So what sort of impact it will have on their total well-being? So what palliative care does is, if you're suffering with side effects, some sort of a pain, you don't have to rush to hospitals, because this pain, these medications that the palliative care team gives is not going to anyhow impact the disease directly. So it is offered at homes, it is offered in hospitals, it is offered in any such facilities like ours. So the best part of palliative care team is patients need not uproot themselves from their comfort zone and come to a facility so that their pain is managed, so that their quality of life is better. So it's a best part of palliative care. And as we have been talking about quality of life, it improves the quality of life. Imagine a person who is unable to eat anything. He's throwing up nonstop because of the chemotherapies. Repeatedly, he's throwing up. In some sort of palliation to reduce his, vomitings and these sort of things, it will give a hope for him that he still can eat something. He can still exercise or, indulge in some cravings for himself. So thus, that is what quality of life translates to a patient. This is not a spiritual session that, where we are talking of quality of life is, okay, wherein we think that there is a God in everybody. No, we are not talking that. We're talking in simple, workable translation of what it means for the patient. It's very, very important. And it can be done by any type of healthcare professionals. It can be done by volunteers. So you might ask me, what can volunteers do in palliative care? Say, for example, there is somebody who is offering palliative care, like our center, which we'll be discussing about at a later time. If you're aware of it, now after the session, you will be aware that there is an organization by name Hospice, which takes care of palliative care, which offers palliative care, both for patients who are taking treatment and patients who have stopped treatment for different reasons. If you share that information to many people, that itself that shows that you are a volunteer. You're taking the services into your own communities. So volunteers play a very major role in offering palliative care. And as we have discussed, it offers comfort on all the 4 planes. Next slide, please. So the next question is, who offers and what do they do? In this context, I'd like to tell you that many people have been working a lot to see to it that there is an early integration of palliative care into the patient care. Most of the corporates, most of the hospitals are thinking on the lines of having a palliative care physician with them, or medicines which are used for palliation for the patients, and have a psychologist or have a social worker in their team. So this is early integration of palliative care into the treatment, right from the diagnosis, along with the physician, a psychologist is involved, a social worker is involved. Then it's an early integration into the treatment of the disease. But it's not that best case scenario presently. People are working towards it. So in a palliative care setup, in a palliative care facility like ours, who all offer this particular care? Who all are part of it? Mainly it's a medical care. Basically, it starts with people come to us Not because we have psychologists here, not because we have social workers here, or not because it's free here. They come here because they want help to manage their pain, help us to manage their symptoms. So they relate to this, but any type of palliative care with palliative medicine. They think that palliative care is palliative medicine. That's the reason they're walking into these sort of centers. That's the reason they want to avail it. So when they come, actually, physicians' first interaction is they interact with the patient, then they address the physical issues. Once the physical issues are resolved, then they will look into other aspects. Then they will open up with other aspects about themselves. Like then they will talk about how the journey with the disease has impacted them, on their spiritual level, how it has changed their family dynamics, how it has changed their, emotional status. All these things they'll start discussing. So physicians are there with us. We have spiritual counselors are there. There are medical counselors. We have social workers are there who talk to these patients. And we have bedside assistants who help the patients change clothes and change diapers with their basic needs. And we have nurses. Mainly, it's care means generally, but it's nursing care. Nursing care is nothing but wherein the patient is administered with different medications or certain procedures are done, cleaning their wound and things like that. And they're volunteers. And most importantly, along with the patient, we deal with family and friends also, or teammates here. So you might ask me, as how does it mean? How does it translate to? When a person is suffering, he wants his family and friends to be close by. He wants them to assist him or her to deal with the disease, like helping him to take him to go out into the garden, or help him share his story of his life, or help him understand how it's impacting him. So family and friends are equal part of palliative care team. We do not say that family is immediately separated from the patient because he's taking palliative care. Family and friends are an integral part of palliative care team for any patient. And there might be so many other specialties, like there are few palliative care centers who might offer physiotherapy for their patients, alternate therapies for their patients, music therapy, art therapy. There are so many alternate ways, diversion techniques and diversion workshops that happen in them. So any of those people who are trying their best, either in the form of a healthcare professional or a volunteer, to alleviate the pain of the patient or alleviate the emotional suffering of the patient, all of them constitute palliative care team. Next slide, please. What serious illnesses are we talking about? If you can see the statistics here, I just put this picture because cancer cases are on a rise. These numbers actually scare us. The projection for 2025 is actually very scary. So what other serious illnesses are we talking about here? Apart from cancer, we're talking about heart diseases, fibrosis, dementia, end-stage liver diseases, kidney failures, lung diseases, Parkinson's, stroke, and many such illnesses. Most of the other taboo that is attached to palliative care is that palliative care is just for cancer patients. It's not for any other patient. But it is part true, because the symptom burden or the pain burden for the cancer patients is very high compared to other chronic illnesses. That is the reason there is a taboo or a misunderstanding about palliative care. But palliative care centers, palliative care services can be availed by anybody suffering with any type of chronic illnesses. Most of the chronic illnesses might not need hospitalization or institutionalization. But cancer, the burden of pain and symptoms is so high that it might result in some sort of institutionalization for the patient. So we're dealing with, palliative care deals with many serious illnesses like the ones that I've mentioned on the slide. Next one, please. So how exactly, okay, palliative care is offered. So how do we go about it? If I'm diagnosed with a disease, I know that I need to go to this particular specialist. I'll make my inquiries. I'll go to a particular hospital of my choice. I'll go to a specialist of my choice and follow his advice. So how do we go about getting palliative care for ourselves? What is the effort that we would put in for ourselves in case we are in that situation? This knowledge is very useful because it will help us in different ways. It will help us in case somebody in our families is suffering, we can share this knowledge with them. In case somebody who is dependent on us in terms of, their social structure, like our dobbies or milkmen or anybody in the structure, if somebody is dependent and they require this sort of services, we can educate them. You can do this. There is such a facility or such a care that you should avail it to lower your burdens. So how do we even do it? So how we do it is, in a hospital, first we need to know if there is a palliative care department in that particular hospital. If it is there, we need to approach that particular palliative care department. It is not a very common scenario presently in India. But what we can do is we can find out, we can Google, we can find out if there are any palliative care centers in our hometown. Google shows, it does show. So first find out what are the services. So go to them. And what do we do when we go to them? We have to know the symptoms that are affecting the patients. First understand, list out all the symptoms, including the pain. What sort of pain is he experiencing? What sort of symptoms that person is experiencing? List out all the things that are affecting his activities of daily living. Like he's not able to walk, he's not able to go to the toilet, he's not able to sleep, he's not able to talk. So activities of daily living, what we do, what we take for granted, we breathe by ourselves. We are not even aware that we are breathing. We assume that we take for granted that we can talk. So for certain people, they cannot afford to take it for granted because of the disease. So whatever activities that are affecting their daily living, then you have to list out and then take the list to the palliative care department. And also take the list of medicines that the patient is using. What are the medicines that he is using presently and what are the doses? So we have to have the complete information about the patient on hand. And usually it is better if a family or a family member or a friend accompanies the patient or some people go by themselves to the palliative care department and talk with the physician. And there is an interesting phrase here like advanced directives. Advanced directives or living wills. What we are talking about is here a patient's wishes of how he needs to be treated in case the disease progresses and he's not in a position to express his needs and wishes and preferences. So we need to understand if there are any advanced directives like that in place. Some people few people when they come to us, they tell us that we don't want any tubes coming in and out of our body. You just leave us alone. If I'm not able to take food through my mouth, I don't want any other alternate arrangement. So they're very specific. They're very specific that they express to their family members that in case I'm sick, please do not put me in ICU. No serious, treatments for me. So they have specific requirements and preferences. So we have to know what the preferences are for the patient. And when we're talking about patient autonomy, we should be aware of all these things and we need to honor them. So we need to know as a palliative, if there is a person is suffering from a disease, a chronic illness, then we need to understand if he has any advanced directives. In India, it seeps into our social wishes also, in the sense that they would tell us that if something happens, I should be cremated next to my spouse in so and so village in my farmland or things like that. Or they would tell that according to this particular religion, please do the final rites. So they have so many wishes and preferences that need to be followed in case the patient is not able to express his own preferences. So these are the advanced directives, mostly in the context of medicine or treatments that we discuss, but it seeps into many social issues also. We need to be aware of all these things. Next slide, please, Preeti. And what one can expect after a visit to the palliative care team. It can be part of, as I was telling, it can be part of their curative treatment, or it can be after their treatment. In case they're suffering from the still suffering from the disease, and the disease has not responded to the treatment. So how is it impacting their lives? So if they want to come to a palliative care team, they can discuss the impacts of the side effects of the treatment and get help from the palliative care team. It's very, very essential, because if we do not address these sort of issues, people might stop the treatment. Even if the patient has a chance of cure, he will let go of the chance because he's suffering from the disease, symptom burden and pain burden. He doesn't want to go through it. He says, okay, let me die. I don't care. This is better. Dying is better than suffering like this. So we have to help people take a decision to go to palliative care or avail palliative care so that they can stick with the treatment. Probably he has a chance for cure. And you'll also get to know what are all the resources that are available in the society. What all are there for him to avail so that it will be helpful for him on social level. There might be some free ambulances attached to hospitals. He can avail it if he's not able to foot the bill for an ambulance. Probably an NGO is attached to the hospitals wherein they can support the child's education. There might be an NGO attached to a facility or a hospital which supports funerals. So they will get to know what are all the resources that are available in their own community, in the society, to support them through the journey of the treatment or after the treatment too. And sometimes many of the families and patients want to know what are the pros and cons of each treatment that is available for the person, for them. Many chronic illnesses have many treatment plans, many treatment options. When these treatment options are availed, it's patient's right to know what is the benefit from that particular treatment and what is the burden he's going to face because of that particular treatment. If the patient is aware, he will take a very informed decision. It's the patient's right. We cannot say that this particular treatment works for 30% of the people. So let's try it out. That's the easy way out for any situation. So we need to encourage the patient to have full information about the pros and cons of each treatment. Many a times people come to palliative care centers to understand, should we go ahead with this particular option or not? So we need to discuss with the medical team and arrive at how it's going to benefit him and how it's going to cause some sort of discomfort or anything like that. We need to address this particular issue from the social angle also. Just because an option is available, we cannot assume that the family can afford it. Sometimes money is a big thing. Probably not for many of us, but many people who are coming from rural areas or most of the country lives under poverty line, So we need to understand what is their financial structure, what is their family support. We need to understand all that when we arrive at a consensus, when we help them out to take a proper decision about the treatment options. And we should always, whenever we're doing any of these things, we have to keep, especially depending upon their religion and their value systems and whatever their goals are, we have to keep all those things in our mind when we advise the patient or we help them take the right decision. We have to be in line with their personal values. We have to be in line with their goals. This is very, very essential because it is about patient autonomy, whatever he wants as per his wishes. Next slide, please. Just a few minutes back, we discussed about integration of palliative care into mainline treatment. That is, if a patient is encouraged to avail palliative care along with his disease modifying treatments, like in case of cancer, either in case of cancer, radiation or chemotherapy and all, when we're advising them to, when they're going for these treatments, if they're advised to visit with a palliative care team, it will help them improve the quality of life. immediately from the day one, so that they'll have that, focus and the intention to continue the treatment. And it decreases depression and anxiety. When we feel that we don't, when we feel that there is not enough support for us in a particular situation, that's when the anxiety sets in. What should we do in case this happens? What should we do in case that happens? So when there is so much of uncertainty and there are so many questions for which they are not able to arrive at for answers for themselves, then there is a scope for depression and anxiety. This can be decreased if there is early integration of palliative care into the treatment. And there is a lot of satisfaction for the family and the patient. They have the strength to, the strength to fight. And in some cases, this palliative care helps the patients to extend lives. There are some conditions applied. It's not like whoever takes palliative care lives for a very longer time. But in certain cases, it helps them extend their survival. Thank you. Next slide, please. So symptoms are managed after the consultation because there is a physician who is guiding. And there are social workers who are helping them to understand and avail the support systems and the resources that are available in their community. And if there are any techniques or any procedures that will help them improve their comfort and well-being, we can share with them. And we can do them to differently. In case we are not able to do some, if we have that network, we can refer them to different places where we can get that necessary support for that person. And with our help, he can come up with advanced care plan. He can decide in case the disease progresses, in case the disease is not responding to treatment. So how to go about it? So this sort of advanced care planning can be made with the help of palliative care team. So this is very, very important because a sense of well-being is established in the community. Presently, if a person's cancer burden is so much in our society that we equate it with death. Once a person is diagnosed with cancer, hardly any cure. We as well consider them as, already dead, as it so happens. So if we address issues like the emotional issues and social and spiritual and, this symptom burden and all these things, there is a sense of general well-being in the society that there is a facility, there is a team in a hospital that we are visiting that will help us with sort of a wellness is created in the communities. It's very important that people be aware of palliative care. People be aware of the advantages of utilizing that particular care. It's very, very important because it directly impacts their daily lives, directly impacts their simple things that we all take for granted. Next slide, please. What about terminal patients? What happens to patients? Okay, before I jump into it, sorry about that. So here we have to understand two words, active patients and terminal patients. Who are active patients? Patients who are taking treatments for the cure of the disease are called active patients. And for patients who have lost the chance for cure because the diagnosis is late, or because the disease has not responded to the treatment, or because they have left the treatment in the middle because they could not afford treatment. So these sort of patients are called terminal patients. So when the disease cure option is closed for patients, they are called terminal patients. So what happens to these sort of terminal patients? Do we offer palliative care to them? Do they have a chance to improve the quality of life themselves? So this is when the option is, the answer is yes. There are two different types of care. Terminal patients are the patients who lost treatment options. They have treatment options are closed for them and the cure is no longer an option for them. Those patients are called terminal patients. The question is, can they avail this palliative care? Yes, definitely can avail this palliative care, but there is a different name for it. So if you can see this particular diagram, you can see that talk about palliative care and hospice. Palliative care talks about integration or support that is given to a patient who is undergoing treatment for the cure of the disease. Palliative care. But when the treatment options are closed, when the doctors inform him that there is nothing much we can do, the disease is progressing, they are the ones who need more of pain management and more of symptom because their disease will continue to progress and it will impact their daily activities. That's support care, that's sort of palliative care offered to terminal patients called hospice. Patients who have 6 months or less of life, they're going to fully succumb to the disease. They're called terminal patients. The palliative care that is offered to terminal patients is hospice care. So there is an overlap. There, because the common goal for palliative care or hospice and hospice care is that quality of life and comfort for the patient. So reduce the stress, provide emotional and spiritual support, and relieve the symptom and optimize comfort for the. So these are all the common things. The patients they take comfort care along with palliative treatment, whereas hospice care patients not going to the regular hospitals for cure because they have a purpose for it. They just take this support care or comfort care. So the care that is offered by Sparsh Hospice, mostly for terminal patients, we not only offer for terminal patients, we do offer for active patients, the patients who are going treatments. Majority of our patients are terminal patients. Next part, please. Am I still audible?
Ma'am, the audio is a bit glitchy right now. Could you please check if you're connected to the correct Wi-Fi network once again? Or the mobile hotspot?
I am connected.
Okay.
How
The
is it
video is
now?
getting a bit stuck. It's showing the network bandwidth is low. I think you can just speak a sentence.
How about now? Is it better?
Yeah, the audio is clear. You can go ahead.
Clear?
Yeah,
Okay.
the audio is
What is audio
okay,
clear?
ma'am. Still getting stuck.
I'm sorry, still getting stuck. Do I continue then?
Yeah, please go ahead.
Yes. So there are some myths associated or no, connected with palliative care. People feel very expensive. Palliative care, availing palliative care is very expensive, which is not true, because most of the time the services that are used by the patient families are not very expensive things. So it is not an expensive care. And I think that once you go to palliative care, people will give you certain drugs and you'll stay sedated and you die. It's a statement we hear from many of the families and patients, which is again not true. And they think that palliative care is some sort of a religious place wherein there are bhajans or prayers to gods happen and some sort of bedside support, patient physical support happen at a medical center. That's what many think. Because we use the word care, they think that, but definitely not that. And many people get confused between, they think palliative care is nothing but geriatric care. You have people at home, palliative care, centers can be, we can put our elders in palliative care centers. Palliative care centers are medical centers. There should be a serious illness. There should be some sort of pain burden or symptom burden. Only then patients can be institutionalized in a palliative care center. And there is people find hardly difference between palliative care and hospice care. They think that both palliative care and hospice care both are same. No, it's not. As we have discussed, palliative care is for taking treatments, and hospice care is for patients actively dying.
Could you please
have been
repeat that
informed.
sentence?
Yeah. Many a times people feel that palliative care is for patients who are dying, who are actively dying, who have been informed by their physicians that nothing can be done for them. They have learned to live with it eventually to the disease, but it is not true. As we discussed, it is not just for dying patients, it is also for patients who are fighting it out. So it will to strengthen their spirits to fight with the disease. If they avail the palliative care, they will have their physical burdens and physical pain and symptoms addressed. Their emotional, social, and spiritual issues are also issues so that they have spirit continuing for the restaurant. Then people feel that if you every palliative care their patient, as if they're institutionalizing in one of our centers or
Can you
anything
go off
like that.
video and talk since the Wi-Fi connectivity is not so.
I just stopped the video.
Right?
Yeah, let's see how it is when you're talking now. You go off video and then have the conversation.
Yeah, ma'am, you can.
I'm going off video now.
Yeah. You're
Right?
Yes,
You
ma'am.
can
Not
I'm
continue
better
talking.
now.
Let's
Yeah.
see.
Okay. Thank you. Thank you, Sajid. So they think that they're abandoning the patient to die. So they think that they are not fighting enough to see that, he lives for a long time. Generally, care is directly proportionate to families wish for the patient to live long. That's a general opinion of our community or our society. That's what we think, that if we care for somebody, we should wish that they live for a long time. It need not be that. When the quality of life of a patient is affected to such an extent that his dignity is questioned, he's questioning his own dignity, he's questioning his own self-worth, then it is nothing wrong in institutionalizing a patient who is in need of that particular support. So these sort of myths need to be, dispelled by all of us, because it's time that everybody avails these sort of services, especially Sparsh Hospice offers palliative care free of cost to patients. So people should be aware there is such a way they can go and avail these services. So I think these sort of platforms will help us. Next slide, please.
Preeti, next slide.
So this is specifically about our organization. So I work as a senior psychologist and hospice administrator at an organization by name Sparsh Hospice. This is a non-profit organization. We don't charge our patient services that we offer, and we offer hospice care. This project is sustained by Rotary Club of this charitable trust with help of the honors, CSR funding and things like that. So we were able to reach around 8,600 families for their loved ones. We could offer something called good death. So good death might sound like a moron in the sense, what is so good death? Imagine a scenario wherein a person is screaming at the tongues because of the pain or symptoms, or he's trying to stand tank one, trying to jump in.
At time in the seminar,
we have got. Pardon? Pardon?
Ma'am, please continue. I think it was.
Yes. Yes. So Sparsh Hospice was able to reach this many patients and offer good death. Good death is not bad. There is dignity in the way a person dies. We provide a place, we provide pain management, we provide emotional support, we provide social support with the help of the network we have with different NGOs, ensure that the person leaves this world with with dignity intact to the extent possible. We help the patients leave that moment without guilt at a later time in their lives. So this is the work of ours. So this is a beautiful facility with 82 beds. Dr. Tangana has given us this land, and Phoenix Foundation has constructed the entire building free of cost for us. So we are able to serve all these patients through the services of ours. We have, as I said, we have this facility that the picture that you're seeing is a 2-bed facility, wherein patients who need admission, they come and admit the patient, families come and admit the patients here. And the second thing is, as we were discussing earlier, go to their rooms and serve periodically. We don't go and see them, but periodically we visit them. A physician, nurse, our nursing aides who help, like social workers, social workers, visit them periodically, evaluate them, evaluate their issues, solve them to the extent possible. So that is our home care service. Home care service is the largest one of ours. We have around 660 patients in that particular. At any time, we take around 800, between 800 to 900 patients in our center and home. And other service that I have to mention is outpatient service. Outpatient service, and when the patient is active in the sense, when they're treated for the disease, they come to Palliative, they come to us for some sort of social support, like they want groceries, they want counselors, they want some medication for their pain and symptoms, they want some diet. They come to us, the opportunity, they these services and go back to their hometowns. That is outpatient work. So if we can't go to them, we request them to come to us. If the patient cannot come to us, we advise a video call with the relative, with the necessary, all the reports. Then we address the issue of the patients. So a lot of beautiful work happens here. So we have a mortuary here wherein we remains of the patients for if the patient, the family is out of the country, we support till they come back. And then we have tie-ups with the graveyard, wherein they allow, like for PL families, below poverty families, they allow free funerals for the families, extremely free funeral for the patient. So we have so few connections wherein there's a few support, skill development, few student.
Hello, ma'am. We seem to have lost your audio.
Call her, please.
Yes.
So while we are
Just a moment.
this, before we move to our question answer session, I would now like each of you to in the audience to take a 30 seconds to answer a poll for us. The purpose of this poll is to help us understand you a little better, so we can better curate the topics that we bring to you. You can also let us know in the chat box how you found out about Vishwa Talks. If you're a Vishwa Talks subscriber, heard about it through your friends and family, or found out about the event on social media. Of late, because of a lot of constraints that we have on social media and Zoom and all, my request to each of you is, if there is a talk which you think is of value to any of your family and friends, please ensure that the talk, the registration piece WhatsApp message is passed on to them. And each of you, please subscribe to Vishwa Talks, because just registering to one event doesn't help. If you subscribe to Vishwa Talks, we can ensure that you get the information of the upcoming talks. I would like to talk to you about the upcoming Vishwa Talks in the next few weeks. So the upcoming Vishwa Talk is by speaker Raghav Krishna. He is the co-founder and founder of Brat. The topic is Dharmic Culture, Ancient Wisdom for Modern Global Crises. The date is 23rd September, 11 a.m. you need to put directly the slide on the upcoming talks, Preeti. Yes. This is because of the colonized thought process that we still have. We requested the speaker to talk on it, and he's come out with his talk. And we have our next talk by Dr. Sandeep Kondepi, consultant psychiatrist and de-addiction specialist, Asha Hospital, Banjara Hills. The topic is addiction, a brain disease. This is on 30th September 2023 at 11 a.m. This was specifically put because one of our audience in one of our previous speakers in our previous talks had requested when we were doing the Montessori talk, she wanted something on addiction. So for her sake, we have curated this and we have put this for her. Yes. Is ma'am back?
Ma'am, she's just joining in a minute. She's joining in from her phone.
Yeah.
Just
Until then, we would like to talk about the upcoming drive that Vishwa Talks is doing with materials. Generally, every Diwali, we conduct a program where people can share, we have a tradition to clean up our homes every Diwali. So Vishwa facilitates door-to-door pickup until Diwali. And there are around 150 slums in Hyderabad. And we were fortunate enough to give in the last couple of years to around 3 slums. People were extremely happy about the material that they have received. Some Vishwa Talk participants were very, very kind to donate very generously stuff at home, whether it is clothes, whether it is toys. And these people at the slums were so happy. And most of them are actually taking on doing their degree or their 11th and 12th. And they came back and they said, Madam, it was so useful that our entire year's requirement of clothes has been taken care of by you. While we considered a huge success that we were able to pick up a few trucks and then donate, we were able to donate to 3 slums out of the 150. It'll be great if more people participate this Diwali to share. We've all, Akhilesh, can you show the website? Is it possible for you to show the website on the material drive? And Trishan, just let me know as soon as man comes online.
Sure, ma'am.
Yeah. So what we've done in Vishwa Talks, see, Vishwa is an organization which is working towards social change. We have 12 different causes. It's about education, it's about health, it's about mental health, it's about children, environment. So we have a whole lot of range of areas we're working on, out of which one of the vertical we do work on is material donation. We've recently uploaded our website where you can come out here. We have already 500 people who have donated previously, around 1,100 people, all the people who have received the material and the people who NGOs who have facilitated in this have given their reviews. Feel free to see it. Go down, Akhilesh. So here you can donate materials. Stay there. Go up. You can donate materials. You can request for materials. In fact, there are NGOs who are requesting us for laptops. If any of you all have any laptops, please feel free to donate them, because as Vishwa Foundation itself is doing a vocational training program for students who have passed out of inter and degree, because it's very hard for them to get jobs if they do not know the basics, whether it is to do a mail, whether it is a Zoom meeting, whether it is an Excel sheet. If they do not know, they don't get jobs. So we're working with these slums to teach. So please feel free to donate laptops. We also request you to get involved in this. If you want to be a volunteer to pick up, if you have a truck where you can help us make 3-4 trips to pick up the stuff from apartments and give it to slums, that will be great. Can you go down, please? We also have, Vishwa helping out aged people if they would like to clean up their homes, and give valuable stuff to people who actually need it. You can go down further. Go down further.
Sorry to interrupt. Speaker has also joined in after.
Sure, I've seen that.
Sure.
So you can, if there are NGOs who would like to receive materials and then again redonate it to orphanages or slums, please feel free to register with us. Can you go down further? Akhilesh, go down further. Go down further. Is there any feedback? You can call us, you can WhatsApp, or you can write to us. Can you go up? Do you have any place, Akhilesh, where feedback is given by people who have already received? Stay down. Go down. Go down. I think this is it, or okay, fine. So anyway, we'll come back to our question answer session. I would like to first thank ma'am. We've crossed 12 o'clock, so we'll be shutting the session and taking on the question answers now. I would like to thank ma'am. I mean, Sparsh is. I have a question for ma'am. Ma'am, who built the building for you all?
Phoenix Foundation. Ma'am, you're on mute. Kindly unmute this.
Who built the building for Sparsh?
Phoenix Foundation.
At free of cost?
Yes, they've spent crores of rupees to build a structure for us. Crores.
Amazing. God bless. God bless Suresh Chukapalli and Gopinath for such a wonderful contribution to our Hyderabad. Real special thanks to him, both of them, and the family and everybody behind it. And it's a wonderful building. I haven't seen it, but from the pictures that you've shown, it's wonderful. I would also like to thank you, ma'am, for specifically coming and talking about this program. Most of us are not clear what is geriatric care, what is palliative care, for giving us clarity on how to take care of the elders. I did not even understand that there is a need for, of course, I knew subconsciously that there was a social structure that the people crave for, that they need some spiritual guidance and things like that. But until you told all this, it hasn't become very clear for us. I also wanted to thank you for, you said 600 to 800 people at a time are taking support at your organization. And that's amazing. It's simply amazing. And to understand that there are people in Hyderabad who are doing this kind of work, I mean, I don't think it was publicized enough.
That's very, very true. The reason why I'm also saying that is, we might think that 800 is a big number, but it is just 2 or 3% of the terminal patients that we are taking. All the other 97% are dying in pain, comfort in their lives, with their dignity violated and things like that. That's the reason we look for these sort of platforms to take us forward into the communities so that many people can avail these sort of services. Thank you for this opportunity too.
Yeah, so I'd like to express my gratitude to Ms. Sarda Lingaraju once again for coming on this program and talking, and to all the participants who every week come and grace this event, and to the Vishwa team for coming out with such lovely talks, choosing such pertinent talks which are necessary. Tushant, thank you so much. And all the Vishwa team, Preeti, Radhika and all, for bringing as such a lovely talk free of cost to people. So coming back to question answers, ma'am, I'd like to understand, are there any programs for adults or children who can be taught on palliative care that can be given at home? Is there any program that you all are running?
Who can be taught, you mean?
Yeah. A 1-day program, a 3-day program. Do you have any such programs?
Yes, we are coming up with a volunteer training program shortly, wherein it's a 3-4 day program wherein people can understand the basic basic knowledge of palliative care can be acquired through those programs. So it's going to be a very interesting program. And many a times, many college students come to us. Yesterday, we went to Sangareddy Government Medical College, wherein we talked to the new recruits that day. And, yesterday they have started second batch of theirs. So we address them as, how it helps this palliative care attitude, wherein how you talk to a patient and interact with their families, how it impacts their well-being. So we had a session there. So please do let us know where we need to be. We'll be there and offer our advice or offer our expertise or knowledge, share our knowledge, so that this palliative care can be taken forward in the community and everybody gets to know about it and avail it in case there is a necessity. Please let us know. We are there. So we go to schools, talk to children about palliative care. So like, for example, next door is Oak Ridge International School. We have gone to that place. We have gone to DPS. So we have gone to many schools like that, many colleges we have gone and talked to the children and students about what is palliative care and how it can be, availed and how it can translate to a good quality of life for their loved ones in case they need it.
Ma'am, are you going to have a volunteer program tied up with schools and colleges? Because Vishwa works with schools and colleges. We would like to understand if there is a program where, a person can come for 1 hour or 3 hours once a week and, either just talk or to serve, to be a volunteer. Is there any such program that you have curated?
Presently, there is no such structured program happening, continue on a continuous basis. As and when somebody invites us to come to a particular college or school, we go. But as such, we don't have any continuum of such program. In case we can join hands and offer to these colleges and students, it would be a lovely thing. We can always discuss that.
Let's let Vishwa and Sparsh Hospice coordinate and come out with such a program.
Great, that would be wonderful.
There is one Mr. Shmuel Yerushami wanting to talk. Please unmute yourself and ask your question.
Okay, thank you.
Yeah.
First, thank you on a very interesting presentation. And I want to ask you next question. What, according to you, need to be a role of government and state authorities in development palliative care for poor and low socioeconomic groups of population?
That's a very pertinent and great question, sir. Thank you for asking that.
Thank you.
Thank you for that, sir. So here in India, many people, like if you have heard of somebody by name Dr. Rajgopal from Kerala, who has been, who was awarded, this Padma Shri few years back. He has worked to such an extent that he got, if morphine or any sort of pain management drug is available in our country today with ease, it's because of his efforts. That's when the palliative care movement picked up, momentum. The thing is, there is no universe, there is no central policy that says that every government or every state government should come up with a policy of their own. There is no such. So state governments are left to take a decision for themselves. So few states do have policies. So what happens when a policy is in place for palliative care is it comes under medical insurance. People can avail it. Every hospital, it's mandatory. It is available for the patients to, approach and take service from that particular department if there is a policy like that. As far as Telangana is concerned, in coordination or in affiliation with the National Health Scheme, they are offering palliative care at every district level. They have a palliative care ward in every district area hospital, but there is no policy as such in Telangana. Many people are still trying for it because policy again translates to burden for the financial budgeting should be done for that particular policy, and all these things, skill development should be done, and all these things will come into play. So still we are all trying for it. I think many heads are rolling for this particular cause. We are trying to see to it that it comes under Arogyasri. We are trying to see that there is a policy in place in Telangana so that many people can avail it, and many hospitals which offer this cancer care, palliative care, becomes mandatory for them to offer. I hope I answered your question, sir.
Yeah, of course. Thank you very much.
I wanted to add something here.
Thank you.
How would it be if the government comes out with a policy on education with schools and colleges? Because I feel these days schools are not catering to the training the children on the real requirements. Like, I don't think schools teach on first aid, schools teach on palliative care, but all of us have old people at home.
True.
All of us don't know this needs to be dealt in a certain fashion. These are life skills. Palliative care itself is a life skill. So if there can be a policy, where it's just like when we were small, we had the SUPW classes or the culture and culture classes. If you could have one class a month or a week where, you actually physically go and serve in palliative care hospitals, I think it will change the experience and the wisdom and the exposure for the child. I think that is a policy I feel that can be added, Shumel, in the policy making.
True.
Yeah. Okay.
So,
another. Yes.
Thank you for that input. Thank you.
Yeah. Another question I have is, how expensive is it?
You are not clear, ma'am.
Yeah.
Audio, bro.
Could you please repeat the question, Shivani, ma'am?
Does insurance cover palliative care?
No, it doesn't.
Is there a possibility for those tax? I mean, at least, for people like us, if we can question that this is not happening. People who have paid taxes all their working lives, right from when they're 25 to they're 75, they've been paying taxes. At least those people, if they can be provided with insurance, at least, people like Sparsh should actually question and ask these things.
I think they are making efforts in that line. I'm sure they are making. I'm aware of it. But I think that's a decision to be taken by top people of our government. But as you said, if there is a policy, if say Arogyasri itself covers palliative to offer palliative care, because they don't have to come to places like even Sparsh Hospice. If it is integrated into their mainline treatment itself, then there's no reason for anybody to go to a different facility or a different doctor altogether. So if that becomes a part of Arogyasri scheme, or if there's a policy in place like that, then it will be, many hospitals will come up and they'll offer palliative care, not as an option, but as a right for the patient. Everybody has a right to dignity, right to self-worth and things like that. Yes.
One, Mr. Surpaneni Prasad. Good morning. Sparsh Hospice is a blessing for those who are suffering from terminal illness like cancer. But correct me if I'm wrong. Once you are admitted into such a palliative center, you are expected to continue with parallel existing treatment, be it chemotherapy or whatever. That means drugs have to be stopped?
No, not at all. We have patients who go to hospitals, who come here, stay with us between 2 sessions of chemotherapy or 2 sessions of radiotherapy. They come to us. They don't have to stop their treatments. So, but we add our own line of treatment just to make their symptom burden less and, to manage their pain and things like that. So the answer to that question is no, nobody needs to stop anything to be comfortable that way. They can still continue to cure the disease, their efforts to cure the disease, as well as have good quality of life.
Ma'am, does Sparsh charge for patients, or does it charge at a subsidized rate? How does it
Sparsh does not charge patients. So here what happens is that when a patient is admitted, we request or we tell the family member to stay along with the patient here in the facility. When that happens, we take care of their food, both their food, like, dietary requirements for the patient, food for the family member, and we take care of the medicines, and we take care of their personal hygiene materials, everything we take care of. So there are no hidden costs or hidden things where we say that, okay, you can stay free, but the doctor's visit is, is charged, or nursing care is charged, or for diapers we charge, or for food we charge. We don't do that. It's absolutely free of cost.
Madam, to whom are you saying as spiritual counselor? This is from Professor Dr. Dilip.
From whom?
Yeah, when you spoke about spiritual, that the patient requires a spiritual counselor.
So depending upon, spirituality and religion are very different, as all of us know. So, but many people connect spirituality and to their religion and ask us to guide them as how to go about that particular spiritual issue. So when a religious solution is requested by the patient himself for his spiritual distress, we encourage the patient to get on with it by himself, or depending upon his request. So if he says, if I get to visit a particular place of my choice, a religious place of my choice, I would feel better about myself, about my spiritual distress. We encourage them. In case they don't have money to travel, we try to collaborate, try to find a volunteer who will support that particular thing. If he says that it needs to be arranged at our hospice, wherein it will help him, then we arrange. There were so many instances wherein we could arrange a religious event to happen for the patient, so that they feel that will help their spiritual distress. But spiritual distress in terms of losing hope and or losing purpose for their life because of this illness, then counselors will come into place. And depending upon, again, the request of the patient, if they say that so and so, if so and so visits, I'll be okay. If so and so helps me out, I'll be okay. If so and so, like a psychiatrist come or some spiritual leader come and visit us, I'll feel better. We'll make it happen for them. But counselors are involved, wherein they sit and talk it out with the patient and try to understand the reason for the spiritual distress. And spiritual distress is so very sensitive that imagine what we all do behind two closed doors every day morning. It's happening on their bed, and somebody else is doing for them. So the dependency itself can cause spiritual distress. I have led a nice life, independent life. I look, nobody saw me naked, but now there are people cleaning me. Why should I even live this sort of life? If somebody made some sort of a small frown was there on the person who was, cleaning them, it might lead to spiritual distress. Spiritual distress need not be about great things. It can be about small, simpler things also. Like then we try to find out the reason, what's causing this sort of spiritual distress. They'll say, it's not worth, madam, let me die. I was the principal, I was so and so great, or I did such a great job. Now I'm here at the mercy of these sort of people, and they're hurting me like this. We resolve that issue. We try to look into that issue and try to find out what's happening. So spiritual distress means different things to different people. So depending upon their specifications, we address that particular issue. Hope I answered the.
Yes, you did. One, Mr. Shyam Prasad says, India produces less than 25 PG medical professionals per year, palliative MD or palliative DNB. Awareness is increasing now through centers like Sparsh. If there is such a shortage of these programs, how do we take care of the country's requirement, ma'am?
That's a very good question. So what we generally feel is there's so much of requirement and the depth for the depth for the provisions or the resources. It's not completely true. If people are aware of it, aware of palliative care, they need not even uproot themselves from their homes. They can still be at home and make use of those services. They can go to a nearby palliative care center like us and take it. We don't need 100 more centers for it. First, if the center is put to its optimum use or the maximum use, that's a beginning of raising awareness. So it so happens that when there is we sometimes wonder if there are, like for a few years back, there was an article in Times of India says that every month or so, around 25,000 people are declared terminal in Hyderabad alone. If you ask me, are you taking care of all those 25,000 people? No, we are not able to, because of two reasons. One, as he asked us, there's no facility which can take care of such, such huge volume. Second thing is, we are not there yet in terms of awareness. We are not there yet. We have to create an awareness for the utility of the program, utility of the care. We have to create a sense of hope and trust in the patients and the families that palliative care will actually help them. It might not help you cure the disease. I've heard a statement from one of the sons, one time a patient was actively dying. She was gasping. She was going to leave very soon, like 1 hour or so, she would die. I asked him, and he was planning to shift her to his native village. Then we asked him, why do you want to take her? She's actually going. Please do not. The answer he gives is, anyhow, she's going to die. And, my people, they cannot spend that much money to come and see her. I rather take this person there so that hundreds of his relatives or 50 or 60 of his relatives can have a look at her. So it's an operation convenience. So it is like, we do not have, we means, I'm not saying everybody, a few certain pockets of people do not have understanding of what is dignity is about. For them, what is dignity? There's like, for a person who goes to railway tracks to, to relieve himself, what dignity are we talking in terms of diapers and things like that? We cannot. So we have to perceive that particular thing from his angle and from his level and help him out. So we are not there yet in this as a society to accept palliative care as a right of each patient. We still think that it's an option. Anyhow, the patient is going to die. So what are we going to do? Going to a palliative care center. All our lives will be disrupted. That's what the family thinks. Here at home, leaving the patient here, appoint a nurse or somebody or appoint an assistant. We all can go to our respective lives and respective professions. Whereas if we uproot him and bring him to the facility, then we have to make time to go come and see him and things like that. So it is not a patient-centric. If it is patient-centric, where we are respecting the patient's autonomy and we are looking for good quality of life for the patient, then, as he said, yes, we are not still equipped to deal with this sort of volume of terminal patients. And I hope that day comes where people realize that actually palliative care helps them deal with the disease in a very balanced way. It's a very balanced way of, there is a way where we can, as a team, we can achieve more than as a single family versus a single family with the support of a palliative care center. If that scenario, that understanding is created in the community, then there is going to be a dearth.
Ma'am, since what age can a child be taught to give palliative care?
There are certain, like especially cancer, there are certain cancers which are diagnosed right at the time of the birth. So from that day onwards, and one of our patients was a Swamiji who passed away with us, was 116 years. So right from whenever they start requiring that support, we can offer palliative care. Whenever, what age is it's just a number. We can offer to them at any point when it is going to add to their quality of life. Even the baby can be 1 month old, 2 months old, we can do it.
How expensive it is to give like suppose we are a 20-year-old or 30-year-old or 40-year-old. We want to plan for our future palliative care. What kind of amounts would you advise will cost per month or per to set aside this money as an investment for our futures? What would you advise?
For just palliative care?
Whatever you want to say, please.
Yeah. As of now, for palliative care, you don't have to save anything because it's run by mostly it's palliative care still offered by non-profit sector in India. Most of the non-profit. If in case in future palliative care becomes an integral part of our mainline treatment, wherein our corporate of hospitals and other hospitals come up with their own palliative care, treatment centers, treatment wings and things like that, then it's a very difficult question to answer, ma'am, because it will be about room rents. It will be about whether it is an air-conditioned room or non-air-conditioned room. If you're talking about just medicines, palliative care medicines or hospice care medicines are not much. They're not expensive. They're not expensive at all. But if you're talking about the add-ons, like, you want very nutritious, very expensive, high-end diet, or, you want some specialized room, you want some attendant to stay with you 24/7, who is, he's an MSc in nursing and all these things, if they come into play, then it's going to be a very expensive, a personal choice.
So anywhere between a regular income of 10,000 to a lakh, depending on our requirements, we can spend on pay. Okay. It is, there is a question here. This type of care, this is from Dr. Archana. This type of care is very, very essential as terminally ill cases are praying for high-level treatment. They are not explained properly. There's another statement being made by Mr. Surupneni Prasad. My mother was under care of Sparsh Hospice during her last days. I must say thank you. It was an overall positive experience, one of the progressive and thoughtful initiative by some good Samaritans and the Telangana government. This is an acknowledgement.
That's so wonderful.
Sparsh.
Thank you, Prasad. Thank you so much. Yes.
Yeah.
There was another question.
Then, yes, there are a lot of queries. I'm just going through one by one. Then there is it considered taboo to take palliative care in hospices? Would people try to do it at home? Is there any taboo around it?
About palliative care, there's not much of taboo because there's a treatment is going on. Patient is still trying to get the disease cured. But for hospice care, there's a lot of taboo. People will think that if we keep the loved one in a hospice center like ours, institutionalization of a terminal patient, if we institutionalize them in a place like this, especially if they're not spending money, then there is social judgment is done. Like, many people question the families, like, why did you keep her in a facility like this? Is it because it's free? Or did you abandon the patient? Did you stop trying for it because you have no money? So there's a lot of taboo attached to it, which I want to say here on this platform that please, nobody should think like that. If somebody is offering it free of cost to us, it's because they're supported by government, supported by many wonderful organizations like Phoenix and SBI Foundation, SBI Card, so many people, so many NGOs and so many corporates support us to extend this care to many people. So we are not doing it free of cost. We are not doing free of cost. We are the front end to offer that care to you. Where we are in back end, we are supported by many, many kind-hearted people and kind-hearted organizations, either they through their CSR or just because they are kind enough to share their, profits and things like that. So nothing is free in this world. Somebody is somewhere getting compensated, either directly or indirectly. So never think like that. Never, if somebody expresses that also, please tell them that they should stop thinking like that. Nothing is free. Somebody else is paying for it. That's the only thing.
From there is an acknowledgement from Mr. Anandam Gopinathan, Dr. Anandam from Thrissur. Congratulations to Sparsh. I wish that palliative care is introduced to families at the time of diagnosis. This is a statement.
That's a fantastic statement, sir. We also very, very fondly hope for that day wherein people come to either a palliative care department in the respective hospitals or come to centers like us and ask us for palliation. We are waiting for that day, and I hope everybody, everybody, like all of us, grow to that particular mental state wherein we accept palliative care, as our right. Thank you so much.
Ma'am, does Sparsh do any program for training nurses for giving palliative care at home?
Yes, when there are certain organizations with whom we have tie-ups, so they come for on-job training after the initial theory training for their things. They come to us. There are certain nursing colleges who send their newly graduating nurses to come to us for on-job training. And when the people come to us and appoint a patient comes and they have an attender, an untrained attender who is taking care of that patient. Depending upon the aptitude of the patient, depending upon the capacity of that particular, not the patient attender, we do train them. We tell them how to take care of the patient, how to look out for his, dignity, what it means to take care of his dignity and self-worth, and what it means to, take care of his quality of life and things like that. Of course, we do involve in it, but it is conditional to the extent that not everybody will seek it. People will seek it only if they think that they need that.
But are there any courses which are training people for this kind of a care?
Yes, there are many organizations which are into this, taking care of introducing, train this. That itself is a profession right now. I think that itself is an opportunity for many people. But I'll tell you one thing. Taking care of patients is one aspect. That's also a very important thing. But taking care of a terminal patient who is 100% dependent on the person who is taking care of them, it has a different angle to it. The person has to be taught not on the skills, on the techniques of, how to administer medicines and all. They have to be taught on soft skills like how to be empathetic to the person, how to have, decent conversations with the person, how to be non-judgmental about the person. It's very frequently we keep hearing that, oh, we did this, ma'am, but, when we go to home visits, we did it, ma'am, but he keeps on complaining. So, we already judge. So how to have a non-judgmental attitude, how to be compassionate, how to be empathetic, how to have good communication skills. Look, not everybody will open up and talk to us just because they have a disease. There's a way to go about it. There is a science behind it. And there's a very humane aspect behind it. We have to engage with that, human side of our personality to establish that deep understanding with the patient. So that itself is a branch, I think. So whenever we have association like that with few organizations which train youngsters for this bedside assistance. So we do train these people about soft skills, and we try to take to them to the terminal patients and advise them as what their requirements are, how to feed them and how to take care of them, how to ensure that they're respected. Yes, that's a very, very, very deep subject, and it all directly depends upon the aptitude of the candidate that comes to us also.
Could you name a few organizations so that our audience can reach out to them if they need help?
We have a tie-up with Seva Bharati. We have tie-up with Reddy Foundation. And then we have tie-up with something called Premier Healthcare Services, wherein they come and we train them for this sort of soft skills for them. Yes.
There is one question from Mr. David. Understood. Will it be possible to receive a copy? This is value to me as crossing from clinical care to palliative for 1 in 2 of my 121 participants. Okay, we are already giving it to them.
Okay. I'll send it.
There is another statement here. Let's do some extensions in Guwahati, Assam, Northeast India. We are open to welcome Vishwa Org. This is from Sharik Hussain. There is another statement from Mr. David. Thank you for so much for the informative session, inspiring, and wish to make a connection. I'm seeking to make an international network to heighten awareness of palliative care with particular effort and understanding on dementia and geriatric EOL terminal care. Again, thank you for your time.
Wonderful.
Some people, Sudha Sonisparsh, planning to extend its activities beyond where it is now. I came in very late. Yeah, I'm from Kerala, and hence the question, there is a paucity of quality palliative care here.
What is the question, ma'am?
You are planning to expand
To Thrissur? To Kerala?
to other places.
Okay, ma'am. That's a good question, because so if there are, like hypothetically, if there are 2,000 centers in the country, palliative care centers, more than half of those centers are in Kerala, ma'am. So Kerala is so advanced in palliative care, so advanced. Most of the people who are fighting for different things in palliative care are from Kerala and other places. Of course, there are many wonderful people fighting it out from different institutions, from national institutions, Tata Memorial Hospital, AIMS, and things like that locally. So many institutions are fighting for it. But majority of the institutions or majority of the centers, palliative care centers, are in Kerala. Kerala is very advanced in terms of palliative care because there is a very strong palliative care policy in place for them, and many of them are aware of the advantages of palliative care there. Mostly.
Ms. Ramani, to everyone, wonderful explanation, in-depth knowledge. I would like to know if there is any offline session happening for children. And Srivani ma'am, great to see 100 Vishwa talks. Thank you. And so, any offline session for children?
It can always be arranged, ma'am. It can always be arranged, but I need to know what exactly are they looking for, and what exactly are they expecting from the system.
Maybe how to change a diaper, how to talk, as you said, more empathetically, how to understand, giving a little workshop with children, and then giving them the basics.
Recently, like a few months back, that was my thought, look, there are elders in the family. Kids need not treat them as patients. So there is a humane angle to treating our elders. So as we said, we can have definitely a talk about how to be around an elder, what are their requirements. And especially elders who keep repeatedly asking the same thing, or repeatedly, they have that, they talk repeatedly, they have to ask something or the other. So how to go about it, and how should our attitude towards them be? And what sort of communication skills help us treat them with respect? What exactly it is to take care of elders at home? We can definitely have a session. I would love to do that. If somebody has a plan for it and few students to attend, I would love to do that.
We'll do that, ma'am. That will be very helpful. And one question from Ms. Roma Pariani. What about tuberculosis palliative care? Where is it available? Is it available anywhere? People do not access palliative care as they do doctors shopping and keep on trying different treatments. I'm not clear.
For communicable diseases, offering palliative care is a little tricky, ma'am, because a lot of safety measures have to be in place. So if I know, there is one center in Hyderabad, which takes care of TB and leprosy patients who are terminal. But it's mandatory for them that family members stay with the patient. So there will be centers like that. But not every palliative care center is equipped to take care of communicable affected patients like that. Because not every, it's about skill development. It is about the training of the staff for that particular type of patients and things and then safeguarding the other patients from these diseases. So there is so much to it. Presently, we are not there yet. I don't know about the future, but presently we are not there yet. But in case there is a specific requirement, I can share it with our palliative care fraternity across India and find out in case in specific place and specific thing. I can always find out and get back.
Sure, that's very nice of you. There's a statement from Mr. Surupneni Prasad. Thank you, Vishwa Talks. Trishant, this is to you for choosing a lesser known but important subject, particularly in the Indian context.
Yes, true.
This is from Dr. V. Sundareshan, good narration. One statement from Sharik Hussain. Does dementia care somehow fall under the purview of palliative care?
Uh, Dementia, of course, end stage dementia definitely comes under hospice care. Yes, dementia, there are 3-4 dementia patients who are with us in our home care vertical. It does fall under it. Dementia does affect their activities of daily living. It does affect their routines. So we go visit them and support them wherein, as and when they require and however they require it. Yes, it does fall under palliative care. That's a chronic illness.
This is the last question. What is the difference between hospice care, palliative care, and geriatric care?
Sure. So geriatric care is helping elders. They have no disease. Because of the age, they feel helpless, they feel dependent, and their activities have come down, they have slowed down, their metabolism is down, and their strengths are down, they become dependent, they're bed bound. So all these patients, if all these persons, if they're taken care, that is geriatrics. Care of elders is geriatrics. Palliative care is a person is diagnosed with a serious illness for which he has to fight it out for months together, like dementia, Parkinson's, kidney failures. We see many patients going for dialysis every week for years together. So those sort of patients. So all these sort of chronic illnesses, when they're diagnosed, and they need little support in terms of managing their pain from catheterization, or some other nutritional support, or for some emotional support. All these things can be, if they're extended to that patient, that is palliative care. Right from the diagnosis, if some support system is developed, some comfort care is added to it, that is called palliative care. But in certain cases, all that effort goes in vain. That is, the patient does not respond to the disease does not respond to the treatment, and or when the diagnosis itself is so late that the doctors inform them that there is no point taking any treatment. It is too late. So even then, for those patients are called terminal, and the care, the supportive care that is offered to those patients is called hospice care. Shall I repeat again?
No. Thank you so much. A wonderful talk. Thank you for the time you've taken to actually so patiently explain and answer all the question answers. Thank you so much. And thank you to all the participants who've patiently participated and asked questions. And thank you to the Vishwa team for coming up with such a lovely talk and doing it in spite of all the breakdowns, handling it so well. Thank you so much.
Thank you. Thank you, Vishwa team, for this opportunity. God bless you.
Shazamam, I request you to join the breakout room link. I'll join there in just a minute. Before that, I'd like to thank Majid, who was part of Team Vishwa for setting this session up, Varshit Ram from Sparsh Hospice, Shashi Das Sir from Sparsh Hospice for setting this session up. Lastly, please take a moment to subscribe to Vishwa Talks to get alerts on every new and exciting talk, exclusive events, and access to the Vishwa community. Follow us on YouTube, Instagram, Facebook, or LinkedIn for future updates. Subscribe to Vishwa Talks. Thank you.